Thank you, Bridget, for putting on record. So just let everyone know that it is being recorded, and we'll share the recordings and the slides afterwards. And obviously, if you don't want to be on camera, then keep your cameras off. Probably better when we have speakers, for you to keep the cameras off while the person's speaking. But other than that, it's good to see you. So if you're speaking, please put your camera on and unmute yourselves. And there'll be a chance to ask questions at the end of the speaker's slides. And we're having a sort of slightly different meeting today because we've got one speaker and then we've got a space for discussion around the cough counter change a little bit later on. So hopefully it'll be a really, really interesting session. I'm looking forward to hearing from everybody. So just a bit of background to the group. We meet every 3 months. Tell colleagues about this group. We kind of welcome anybody with an interest in personalised cancer care and primary care to join. So clinicians, non-clinicians, patients, third sector, etc. So please do share widely. We did lose a few members when we transitioned over to Wessex. So we're still growing the group, but we're back to about 100 members now, which is great. So we keep that going. We aim to be informal, but obviously we don't want our speaker to be too interrupted. So questions at the end of the talk is probably better, but you can put things in the chat as we go. And if it's really pertinent, we can pick it up. I think I've probably covered this already, actually. Yeah, okay. So with no further ado, I'm going to hand over to our speaker today, who's Justine Shenton, who is the Southport Macmillan Centre Manager. I hope I got that right, Justine. I'm going to hand over to you now to speak. And do you want me to do the slides for you, or do you want to take control?
You do them, yes, please. Thank you very much.
Right, no worries.
Thank you. First of all, thank you very much for inviting me along to your meeting. It's a lovely opportunity for me to speak to people from all over the country, actually, about our service and maybe hear if you're offering something similar or your thoughts on it. So I'm the Centre Manager for Southport and Formby Macmillan Cancer Information and Support Centre. And for those of you that don't know, we're based on the northwest coast. We're between Blackpool and Liverpool, and our local authority is Sefton, and our ICB is Cheshire and Merseyside. And the borough of Sefton has 2 primary care networks. So we're in the north part, Southport and Formby PCN, and then there's a South Sefton PCN as well. They mirror the historic CCGs. So that's kind of a little bit of geographical background context. Thank you, Sandra. Oh, there we are in the team. So I've got a nice, well, even we've got one more person now. So I've got a nice biggish team, actually, working closely with GP surgeries in the Cancer Navigator, Cancer Specialist Social Prescriber roles. And we also have a member of staff who is a traditional information support worker for the Macmillan side of our service. Thank you. So as a Macmillan Centre, we're quite unique because we are based in the community. We're not in a hospital trust setting, and also we're not affiliated to a hospital trust setting. So I know some trusts have a community outreach element, maybe a community hub. We're actually a totally separate organisation from our local hospitals. So we are Southport and Formby Cancer Centre CIC. So we're a community charitable business company. We're based in the town centre of Southport, not in a clinical setting. We're available for people to drop in. We're open 10 till 4, Monday to Friday. Been very busy on drop-in recently. We're available for professionals to make referrals, not only GPs. So we're set up in a particular way for GPs to make referrals, but also clinical nurse specialists, practice nurses, care coordinators can all make referrals into the service for us. Because we're situated in the community, we've got great links and networks and support from the local VCF sector. And we also benefit from our own team of volunteers who help support our groups and activities. Thank you. So in terms of practical support for people affected by cancer in our Southport and Formby area, we have the Specialist Social Prescribing Link Worker team. So I have a team of 4.5 full-time equivalent staff who work closely with local GP services, and we have our service available to anybody with a Southport and Formby area GP. So sometimes people might live just outside our geography, but actually they've got a GP within our geography, then we offer that service to those people as well. And the team can make onward referrals into clinical support such as dietitian, OT, the reablement service out of hospital, physiotherapy, you know, all those kind of usual clinical support services that people might need to access through a GP referral, we can refer directly into, and also specialist psychology support. So making those referrals is a big part of our role, and it saves GPs time. That's the idea, really. We also have part-time welfare rights advisor who is funded through Macmillan, the charity, particularly to work with our service users. So we're able to get really robust and timely welfare rights advice for people in the community, face-to-face if needed. And she can do a whole assessment around maximising income, also perhaps looking at debt, looking at fuel poverty and food poverty. So it is an excellent service. We run health and wellbeing events, which is kind of a Macmillan traditional offer. And we ran one very recently, which was a focused information event about physical activity. I'll come a bit more onto that later because we've developed a lot of work in that area. We hold other outreach events, and we also work closely with other local charities and get support from them in terms sometimes of small grants for people in difficult circumstances, as well as practical help. Thank you. So one of the key things that we provide to cancer patients and their families is emotional support. So be that a listening ear from our own link workers who can work with the person for as long as they need it, and even schedule regular emotional support calls if needed. We offer HOPE courses, which again is a Macmillan offer some people may be aware of. And HOPE stands for Hope to Overcome Problems Effectively. It's a 6-week course looking at supporting people who've perhaps finished their cancer treatment and just need some guidance and a little boost around improving their well-being going forward and achieving their goals in the future. We've started a course called Alchemy, and that's for people living with advanced cancer. We are experiencing more and more referrals for people with a kind of treatable but non-curable diagnosis. So living longer term with advanced cancers. This course takes some elements from HOPE, but takes away that focus on kind of now you're better, let's see what we can do next, to looking at getting the best out of life whilst living with a continuing diagnosis. We offer counselling in the centre, person-centred, 6 to 8 sessions for the person affected by cancer or family members. And then we have our regular support groups, which might be around a specific condition, or it might be around an activity, and they're very well attended, and social evenings and events. So it's quite a nice holistic service, really, combining the two elements. Thank you. We've recently really developed our physical activity offer. I'm sure people are aware of all the research recently that's appeared in the press around the benefits of exercise for people experiencing cancer, for prevention of recurrence, improving reaction to treatment, and so on. So we've really taken this on board in the centre. One of our staff now is qualified to a level 4 cancer rehab level. And he can offer one-to-one help and support for people either in treatment now or post-treatment, to help develop a tailored exercise plan that's best for them. We also offer a range of our own classes. The reason why we've developed the classes is because we've found a lot of our patients express a preference to exercise with other people affected by cancer. And for example, this morning we've had an aqua aerobics class, and a lady has just come in to see us to say how much she enjoyed the class, how relaxed and happy she felt being with other cancer patients in the water, because she was feeling lack of confidence in her body image and so on. So I think that really works for us, and we do it, thank you, partly in partnership with our local authority provision, which is Active Sefton. So we're doing swimming and aqua aerobics. We've got sole use of a pool and changing rooms, marvellous, once a week. We do walking every week, and once a month an extra one. We have a yoga class, we have 2 circuits classes, and we have chair exercise. So we hope that there's something in there for everyone, and even people who are struggling with mobility and strength and so on, perhaps during treatment or post-treatment, can come and try the chair exercise and then start to build up their condition again, all supervised properly, as I say, by our level 4 trained specialist PT. Thank you. Oh, so I've got a couple of case studies now, and I think this is an example of how having the social prescribers within the traditional Macmillan Information Support Centre really gives quite a wide offer to patients. So Mr. B has multiple myeloma. Before he accessed the Specialist Cancer Social Prescribing Service, he was experiencing low mood, lack of motivation, difficulties in walking. He was referred by his clinical nurse. Following an assessment by the social prescribing link worker, he accessed our counselling service, a hope course, comes to a shared reading poetry group, and he's found his mood improved a lot, so that he could start attending some of the physical activity classes. And he goes to chair-based exercise now. He's walking more, reporting less pain, having a more positive outlook. And on a practical note, we've also supported him with a blue badge application. We've liaised with his doctor's surgery about his pain relief, and he has found this to be very helpful. As his cancer has progressed, the patient has attended a new course we have developed, which I talked about before, the Alchemy course for people with advanced cancer. But generally, he's feeling a lot more positive in his attitude and able to make more out of life. Thank you. And this is another case study as well. So Jay was referred to our service by a GP surgery. She was very worried about her cancer diagnosis and was experiencing anxiety and difficulties in sleeping. She was due to have surgery, but not sure whether this was going to be able to go ahead due to her being underweight. The Specialist Social Prescribing link worker was able to carry out a short assessment, look at her best hopes and her situation, what might help with her weight difficulties and her anxiety. Her GP had already referred her into a dietitian service, but our social prescribing link worker was able to follow this up, as we have a very good working relationship with that team. She was seen by the dietitian the next day and prescribed some Ensure products to enable her to put on enough weight to have her surgery when the time came. Then we went on and referred her to the health psychology team for help with anxiety and sleeplessness, who she continued to see over a period of weeks, and she was also prescribed some medication by the GP. The social prescribing link worker was able to give more information to the dietitians and clinical psychology that meant that she was supported in a timely manner and didn't need to go back to see her GP or chase up referrals for herself. Following her surgery, she's also benefited from a hope course, which I've talked about before, and attended some support groups with other people really in the same situation. And we keep in touch with her for emotional support. Thank you. So just really to summarise how this Specialist Cancer Social Prescribing service works. Patients with a recent diagnosis of cancer are offered a referral to our service by the GP surgery. We work on the EMIS system, so they can be referred to us as a task on EMIS, and it goes straight to the named cancer navigator, social prescriber for that practice. So it's set up in the most clear and simple way for GPs, so it's not an onerous thing for them to do. It should be straightforward. The allocated social prescribing link worker will contact the patient by telephone to explain our service and offer a follow-up appointment, either in person, usually in our centre, or over the telephone. We have a 10-day target for contacting people. We almost always contact people within 2 or 3 days. We offer the service in a very timely way. Once the service is, our service is person-centred, the worker will carry out a short assessment based on the Macmillan Holistic Needs Assessment, which you might be familiar with, and then carry out any actions needed and agreed on, such as onward referrals to health professionals or inward referrals to our support groups and programmes, specialist welfare rights, and the counselling service. And then the worker themselves will probably carry out some of these tasks, such as applying for blue badges or offering ongoing emotional support. I've told you about the specialist rehab personal trainer. The social prescriber can work with the patient for as long as is needed. And that's a difference really from our service from a lot of other services. There's no cut-off requirement. So we're not working to a 12-week schedule or anything like that. Obviously, when the person needs more support, then we will offer more intense support. Then we might get to a period where we're saying, you know, we're very pleased that things are going well for you. You can get back in touch with us in the future if needed. So we work closely with Southport and Formby PCN to provide this service. Sorry, I'm getting a bit distracted by pop-ups. Sorry about that. Our roles actually come under the R's scheme, which I'm sure you'll be aware of. So the social prescribing link workers are employed under the R's scheme, and instead really of them being based in surgeries, as might be the case in other areas, our PCN has chosen to base them within the Southport Macmillan Centre. So that's the difference really, but the role is a primary care role. So we report into the PCN. I do quarterly reports for the PCN on things like number of referrals, which surgeries have referred to us, whether the referral has come from that surgery or whether that patient has come to us via another route, such as through a clinical nurse specialist or a drop-in self-referral or another health professional. And we also look at the number of follow-ups people get, how long our calls are, how much emotional support, what sort of level of interaction. So we're reporting that back into the PCN on a quarterly basis. We've got a really positive working relationship and there's a lot of positive discussion. As I say, we have the added value of being able to base this service within our established Macmillan Cancer Information and Support Centre. So Macmillan have had that model of kind of pump priming their services originally. So when we were first set up, we had, I think, 4 years of Macmillan Cancer Support funding to run the centre. And then we were fortunate that our local ICB, CCG as it was then, were able to pick up the funding. They've continued to fund us, which is marvellous, and we're so grateful for their support. So that Macmillan element of the service, which really is the building and the drop-in and the health and wellbeing events, the hope courses and the alchemy and the support groups, is funded through the ICB, and then we host the Cancer Specialist Social Prescribing service. So in a way, we hope that patients get the best of both worlds really. They can come and join in the activities in the centre. They can also have the person-centred individual support from the social prescribing link worker. So we hope that their experience is enhanced in that way. Thank you, Sandra. And there we go.
Yeah, I think that was your last slide. Thank you, Justine. I think there's one question in the chat for you. I don't know if that's what was distracting you when they were popping up, because it can be a little bit. It's a question from Amy Sanderson saying, I'm interested to know what training you undertake in order to deliver the link worker service.
Yes, that's an interesting question, because it's there isn't exactly a formal social prescribing qualification as yet, but I believe there is one in the pipeline. And when it comes out, it might be later this year. It'll certainly be offered to our staff. We've been extremely lucky with our recruitment. So we have former nurses in the team, we have a former midwife, we have qualified counsellors in the team, and people with strong community backgrounds. So in fact, we didn't ask for a specific qualification when they were recruited. We asked for at least a level 3 in a relevant qualification and experience. So we've sort of learnt as we've gone along. There's a lot of Macmillan training around person-centred cancer support and around this kind of role that people have accessed. And then also most people have done the holistic needs assessment training for Macmillan as well, which is all kind of around that area of personalised care.
Thanks, Justine. Does that answer your question, Amy, or was there anything else you wanted to know?
Yeah, that were everything really. Well, I just didn't know if you were following the Ascend framework as well, if that's something that you're embedded in the role.
Yes, we do follow the Ascend framework. Yeah.
Thanks. So, Amy, I'm not sure if you've frozen, but hopefully that answered your question for you. I've got another question here from Kath Malhotra from Owen Partners. Really interesting presentation. Have ours also covered the cost of the cancer rehab trainer? Which is an interesting question, I think.
Yeah, good question. And the answer is no. Because of our setup and our situation, we're able to fundraise, and also we get donations. So the role that person has is a general the cancer specialist social prescribing role. With the agreement of the PCN, some of his time is devoted to doing the physical activity work. We actually paid for the training from donations and grants, and we're also using donations and grants to pay for things like room hire and equipment in an ongoing way. So in fact, it was a small Awards for All grant that helped to cover part of the training.
Thanks. Does that answer your question? Okay, Kath.
She says thanks.
Yeah. Okay, I can see that. Thank you. And there's a question about age ranges. So do you offer this service to patients of all ages?
We're 18 plus. So if you look at our demographics, just like with cancer, really, most of the people that we work with are in the 60 plus category, and the next category would be 40 to 60. We do occasionally get some younger people, but we more or less follow the national trends on age and also on cancer types, to be fair, you know, so the most common cancers are the ones that we see the most, and we tend to see mainly people 60 plus.
Well, I'm going to jump in for a question, actually. When you were talking, I was thinking about kind of integration, and I was wondering if there's much or if there's opportunity for your H&As to be shared with secondary care and vice versa. You're able to access H&As that have been delivered in secondary care. How does that work?
We can do. I mean, we've got really good relationships with the CNSs, and you know, some particular departments we work very, very closely with, and they will, you know, obviously with the patient's consent, occasionally send over a H&A because they'll refer to us directly, and they it may be that referral is part of the H&A, you know, so a need has been identified.
Problems, right? I might need some antibiotics.
Or there's somebody who's not on mute.
Bit low, bit my nails.
So you bit your thing, bit nail. Okay.
Oh, I think I fixed it. Sorry about that, Justine.
No, not at all. So, you know, a need might be identified in a H&A, like for socialisation, for example, or I suppose more obviously for the counselling service, etc. So the referral to us is as a result of the H&A taking place in the hospital.
Another question, any other PCNs in the area running a similar model that you know of?
Yes, so as I say, in Sefton, we're divided into 2 PCN areas. So we are the north of the borough, Southport and Formby, and then South Sefton covers the next little bit after Formby, which is Hightown, up to North Liverpool, which is Bootle. So it's a different type of area, really. It's more kind of post-industrial. There's probably more, well, there is more deprivation and health difficulties and so on. South Sefton PCN also commissioned a specialist cancer social prescribing service, and they went for the local CVS as the provider. Sefton are great, they're very community sector minded. So that team is based within the CVS, and they do their work out with home visits, meeting community venues, etc. Unlike ourselves, they don't embed that service within the Macmillan Centre. And in fact, there isn't a specific Macmillan Centre for South Sefton. However, there is one in the local hospital trust. But they work on the same model. Ours rolls the same. Yeah.
Thank you. And CBS, what does that stand for?
CVS, it's the Council for Voluntary Services. So it's the umbrella organisation for the voluntary sector. Most areas have them. Yeah. Thanks
for clarifying. Thanks.
That's okay.
Yeah. Any further questions for Justine? Does anybody want to come on camera and ask a question, or have we answered most of them?
Do you want to ask me what our challenges are? That's a good point.
I was going to ask you about funding. So it sounded like you've got a sustainable model up to a point, but I think given the kind of current challenges, even for the integrated care boards as your funder, it feels like 2 years ago that might have felt like a very sustainable model, but I'm wondering how you're kind of feeling around that now, and how kind of safe do you feel the service is?
Yeah, great question again. I mean, we had up until, well, we still got it up until the end of the month. We have a member of staff commissioned to work in West Lancashire. Now that funding will come to an end from Macmillan at the end of the month, and I can't get any local health funding to pick that up, and that will all go. So yeah, it's a tight situation with funding at the moment. As we have always been, we're funded annually. We just pretend we've got long-term funding, because otherwise I think you can never plan. So every kind of January, February, we hold our breath and hope for good news in March. So there's 2 services that are annually funded. The information support element, which I said was funded by the ICB, and the primary care network funding for the social prescribing roles, both come to an end at the end of March 26. And I do feel worried that we may not get all our funding, we may not get any of our funding. It's a very difficult climate at the moment, and it's a valued service by our funders and commissioners. I think they recognise the value in what we do, but that doesn't mean that they're going to have the means to fund us going forward, and we realise that, so we're just going to have to hope for the best, I think.
These are tricky times, aren't they?
Yeah.
Is that your kind of main kind of challenge, do you think? Is it the sustainability sort of financial challenge, or is there anything else that you wanted to mention?
I think that is definitely our main challenge. And I think when you're talking about large commissioned services, or for us it seems large, that sort of funding is hard to replace. Yes, you can find money for development work from grant funding. You might be able to fund a post or 2, but a whole service is very difficult to replace when the statutory funding goes. And as I'm sure everybody's aware, Macmillan Cancer Support itself has made massive cuts recently, and so where we might have turned to them for support, we're unlikely to get any financial support. Well, we won't, because they're in a difficult situation themselves. Other than that, from the Specialist Social Prescribing service, I think we've had, like a lot of people have in these additional roles, we've had an ongoing issue of having to remind GPs and staff, surgery staff, that we're here, again and again and again, that we're here and this is what we do, and that we're the one that you need to refer to when the patient has cancer. And you can feel confident in referring to us because you commission us, and as staff change a lot, particularly with new roles coming up, like care coordinators in surgeries, there's almost ongoing need to refresh surgery staff that we're here. There's a general social prescribing team in our area who work with people with issues around loneliness and needs for emotional support and so on, social isolation. So sometimes they get our referrals, and occasionally we get one of theirs, but mainly they'll get ours. So it's a case of having to keep going and reminding surgeries that we are here. Actually, we're part of the R's service, you know, please do refer to us. And we get a good level of referrals. Then you might have a staff change and then you seem to be forgotten to a bit, you know. And I know you're coming on to discuss the changes to the QOF, etc. And this sort of thing also can impact on services like our own, because maybe the attention goes off ourselves because the targets are not there in the same way, you know. So these are definite challenges for us, you know, and proving our worth and reminding the doctors of what support we give to their patients. So I do a lot of talks. Staff go out to surgeries. We've developed an information pack for surgeries, not only to give out to patients, but also for the staff to be able to see at a glance what we do. I think there's like a little public misconception about Macmillan that we're mainly for end of life. Obviously, we're not at all, and we work with people around new diagnosis and so on. So some of these are the other challenges, as well as the funding that you mentioned. Thanks, Sandra.
Thanks, Justine. I think I'm probably going to end your section here because I want to make sure we've got some time for discussion around the QOF. But thank you. I'm sure if there's any other questions, people can pop in the chat. And are you happy to share your email address as well, Justine, in case people want to get in touch?
Yes.
Thank you. It's really, really informative, and it's a very nice segue actually into discussion around the changes in the QOF that you mentioned. So thank you for your presentation and answering all our questions. So we're going to just move on now then to think about that as a group. So just to kind of frame it, I thought it'd be useful to think about how is it going to affect you kind of in your practice, in your neighbourhood, in your PCN, in your system, and thinking about what people might be doing in relation to that. What do you think might be the incentives now that the QOF is gone? Is there anything else that you think is a useful kind of hook for cancer care reviews or personalised cancer care to remain a priority? What's your system planning to do that? And is there anything we can do to collectively as a group to address this challenge? I guess that's my questions to people here. But yeah, interesting to hear people's thoughts and hear what people are thinking is going to happen in their areas. So I don't know who'd like to kick off. Just raise your hand. Becky.
I'm happy to kick off. So what we've seen, so I am a primary care nurse facilitator in Sussex, and our role over the last 2 years has been to support primary care, specifically with cancer care reviews and the improvement in terms of quality. What we've seen, unfortunately, since the indicators were retired, is that certain practices and PCNs have decided to discontinue these conversations with patients going forward, and are very much citing that, you know, as all services, that they are very strained, and they have to quite simply focus their time and effort on the elements of care that are actively bringing in money, despite them having been income protected for the last year. On the flip side, we are seeing some practices who actually, you know, those who've really heavily engaged and worked with us over the last 2 years and have made really amazing improvements to their service offer, who are saying, well, it remains best patient care going forward, and therefore we want to continue it, and we've been able to clearly evidence that this is useful going forward. Obviously, we've very much changed our sales pitch from this is what QOF says to this might not be an immediate money maker, not that it was ever a big one anyway, and instead we need to look at this in terms of being best patient care, but also a time resource saver and money saver going forward, because if we're reducing unmet needs, then also hopefully we're reducing repeat appointments back in and all that kind of stuff. From an ICB point of view, and also our local alliance, so our roles are 2 years fixed and they come to an end in August. There is currently a budget that's been earmarked by the Alliance to continue our roles, but because of the situation that is happening with NHS England, which directly affects the alliances, and then our ICBs are also one of the ones that are having to merge. There's just a recruitment freeze everywhere, so no one can be seen to hold our posts at the moment, and it's becoming quite political. So we're working at the fact that our roles are ending, and I think that's also sending quite a detrimental message out to practices, unfortunately. Sorry, and one last thing, in terms of what are we doing to sort of shape it for the future. So I've written a 95-page document highlighting why is it important to continue it, what are the benefits both for practices but also for patients, and I've tried to gather evidence to support that going forward. That document, being lengthy, is going to be quickly sent out, and then our alliance are also going to make it a more practical and user-friendly toolkit within their website, so hopefully then that can be used by general practice going forward. I'll be quiet now.
Thanks, Becky, and thank you for sharing your sounds like sort of multi-layered sort of challenges within Sussex. But I think probably what you're describing is quite similar to what other people, I suspect, are similar challenges that people are facing in other parts of the country as well. So it'd be good to hear other people's ideas. Justine, I'm going to come to you in a second. A quick question for you, Becky. Would you be happy to share your 95-page document with the group?
Yes, more than happy. It got officially signed off by a primary care advisory board this morning. So I think that means I can share it. So yeah, more than happy to share. And I think also the other thing that I forgot to say, I think we also need to be acutely aware of the impact that this is going to have on our voluntary and third sector services. So I was at a network meeting last week, and they're already seeing an increased need and an increase in confusion in patients. So I think also going forward, we really need to consider that and how we're supporting them in terms of training and supporting patients appropriately going forward. But yeah, I will share.
Thank you. And I think that's a really interesting point, actually, about the impact on other services. And that might be a good thing that we can think about how we might, how we might kind of measure that and collate that evidence. But let's come back to that. So Justine, you're next.
Oh yeah, I mean, that really resonated with me, Becky. And I was just thinking, for many years we've taken this playing again a dangerous game. I think we've taken this almost devil's bargain approach around things like QOFs, to say, look, we'll help you to achieve this, because then you've got a tick in the right box and you get more money, when really, I mean, all the time it's been about best patient care, and now we're having to flip it and talk about, actually, this is what we ought to be doing morally and ethically. This is the right thing to do. But for a long time we've played the target game, and I think this is a difficulty now. We need to flip the narrative, but yeah, expressed very well. And it will impact on our service. We're in the voluntary sector, and it's not just that the need increases, it's that your funding security decreases as well when these things happen. Thank you.
Thanks, Justine. Next, Ellie.
Hi. Yeah, we have, we don't know, we've got 81 practices or 82 actually, in Lincolnshire, and we don't know yet the direction of travel for all of them. We've had a bit of a mixed response so far. Like you were saying, Becky, some that have come and when asked have said no, we're not going to continue it, and others who said, what, actually we think this is really important, we've got it all set up, we're going to carry on doing this. We've also had some feedback that because we've introduced electronic H&As in partnership with Macmillan for use in the community and with primary care, and one PCN has come back and said, what, we weren't actually great at cancer care reviews, but we really like these electronic health needs assessments because they're a framework to hang the conversation on, and because they don't have the same, certainly in Lincolnshire, in some PCNs, they were very, very clear that only GPs could do cancer care reviews. We had some that were happy for other staff members to do it, but some practices were very very, very clear about no, only GPs. But actually the HNAs seem to bypass some of that, and they seem quite popular. So we are hopeful, we're optimistic that we can continue to build that, even if we have lost some of the hook that we hung cancer care reviews on. And I think the other thing I wanted to mention that is already proven a little bit difficult for us, and I think will continue to prove difficult, is that all of the cancer QoF markers have gone. So because our GP practice will be no longer having to hold a cancer registry, our data collection is going to be much more tricky, because that's what we've always used as a baseline for our cancer cases in the county, and without that we are not going to know, essentially, at the moment. And I know that's not a very constructive thing to say, but I just wanted to flag it and wonder if anybody else had knew what to do, basically.
Thanks, Ellie. Hassan, I'm going to bring you in.
Thanks, Sandra. Hi, everybody. I think it's a really important topic for discussion, and quite timely, but also it's something that over the last couple of months I think has really highlighted to a lot of people the incredible work that many of our colleagues are doing for patients in conducting cancer care reviews and providing that holistic all-round support for patients that clearly was not done to a good enough standard before this, when it was just conducted by GPs like myself. I was really sad to see the QoF indicators get retired, because as soon as I saw them, I knew straight away that this was going to lead more than anything to a detriment in patient care, and what's good for the patient, but also going to lead to widening of inequalities in patients. So already we're seeing from Becky and Ellie that actually we've got some practices that are really quite happy to continue on with it or feel it's the right thing to do, and other practices that are absolutely not going to do it. So you can end up with patients at two different practices in the same building who are doing completely the opposite thing for patients, and the patients that will get a cancer care review are going to be significantly better supported than those that haven't. And I think we need a really clear national message from our leadership, be it through Macmillan and the Cancer Alliance, as to what was it that we tell patients, because we're going to have a complete mismatch in expectations from patients. If I was expecting some sort of review from primary care, and now you're telling me that you don't have to offer it, and what that response would look like, I don't think it's right for primary care to say we're not going to offer it because we don't have to offer it anymore and don't get paid to offer it anymore. Sends a really negative message out to patients that it's just all about tick box exercises and getting paid for the work that you get done. So this is something as a Northern Cancer Alliance we're looking at. I'll be honest, I was kind of hoping that we were getting similar messages from across the country, because we haven't put our message out from the Cancer Alliance yet, because I wanted to see what was happening in other places and whether we were an outlier, but it seems very similar across the board. So I think we're going to probably push the line of to offer it to patients if they can, and that we very much advocate cancer care reviews, but completely understand that practices may feel that they're not going to do that anymore, or they're not going to be able to offer it anymore. And I suspect that there may be some support for that from the LMCs to say that this is no longer work that is funded, so we don't have to do that. So I think there's practices are going to get stuck in a position of whichever thing they do, there's some pros to it, some cons to it. And I think as alliances, all we can do is be advocates for the patients and understand the challenges that primary care are facing, and be that sympathetic ear in the middle that helps to encourage and bring all that together. But I think we'll see a big fallout from this in the forthcoming 12 to 18 months, I would think.
Thanks, Hassan. Some really pertinent points there, I think, around the sort of challenges with the funding going, and the pressures on practices to stop delivering on this. But obviously, severe kind of consequences for patients, and that kind of health inequity that's being driven by those decisions as well, I think is a really important point. I can see Becky, you've got your hand up. I'm going to come back to you in a sec. I just want to pick up something in the chat around the collection of data. So I think the QOF indicators include the removal of a register. Clearly, I think, though, that practices still need to code patients who have cancer. So in terms of the cancer data being there, it's there, but it's there in a different format, in that you haven't got a register, but if you ran a search, you still be able to find those patients. So you should be able to extract, from my understanding anyway, of how primary care data collection happens, you should still be able to extract who's got cancer and who hasn't. That's my understanding. But certainly the QOF indicator for that has been removed. Becky?
One of our thoughts down here was about using the new ICTs which are popping up, the integrated community teams. I don't know if that's just a Sussex thing, but my understanding is that it should be national. And the ICTs that no one quite understands, and then you think you understand it and you go to another meeting, you're still not quite sure. But the neighbourhoods, and it's meant to be MDT working and care in the community and ticking all the lovely buzzwords that we have at the moment. So one of the thoughts that we were having were actually, well, with actually, could that work be moved into the ICTs? And are we looking at having these conversations in community hubs and with, for example, social prescribers who can also still access clinical records? So we, my feeling is that would be a logical sort of place to take it. And there was lots of interest, but again, unfortunately, some of the messaging that we've had back is that in terms of funding and staffing and all the issues, that they're having to focus on the bigger earners in all of this, even though there's a want and need. So I don't know if anyone's explored something similar to completely remove these conversations from an actual physical practice and actually have it in more community hub settings instead.
Thanks, Becky. I think that's a great question. I think in Wessex, that's certainly something we're thinking about, what the opportunities might look like in terms of the integrated neighbourhood teams. And I guess the NHS plan when it's released and the cancer plan when it's released might give us some direction. Justine, you've got your hand up. I don't know if that's a legacy hand or okay. So I'll ignore it in that case. And then Tracy.
Yeah, I was just going to say, so I work for Shaw Medical down in Dorset. I've been here nearly 3 years as a cancer nurse. So I basically do all the reviews and I'm completely funded by the PCN. But also what it's opened is that, that joined up working with secondary care, and we've seen a reduction in our hospital admissions, and also managing the patients who are living beyond their treatment, because that's the other thing that the GPs are going to end up expected to pick up unless that piece of work's not funded as well. The patients who've completed their treatment, and as we know, there's a lot of patients now that are on treatment for a number of years that are complex. So I work really closely with our community. We do have some oncology teams, but with our district nurses, and we do a lot of proactive work to avoid admission and also end-of-life care. So we're going to continue looking. I'll be alerted for all the new cancer diagnoses. So we've got about 3,000 patients at the moment with a diagnosis. We have a 58,000 population across our 5 GPs, but we all work as one PCN. So I know it's something that's not really happening in other PCNs, but also with me and Post, it's opened up a whole new avenue around prevention and diagnostics. We're working really close. We've now got a research team and work really closely with the Alliance to look at things around prevention and screening, which obviously opens up avenues for funding from other places as well. So this is a bigger picture. There's so much, isn't there, with cancer? But the patient satisfaction has been I suppose they don't know any different because it's always been here, but we're now getting to the point where other patients are like talking to other patients within different PCNs, and have joined our surgery. So
Thanks, Tracy. And I think some really good reminders there about proactive care and the kind of opportunities perhaps to demonstrate that proactive care will help reduce demand for later on down the line. So I think that data collection that you're talking about is going to be really important to evidence that. So thank you. And also good to hear that your work continues. So very pleasing. Amanda, I can see you've got your hand up. Then I think Justine, you've got your hand.
It's just really a quick one, because I know when Becky was talking about like the neighbourhood health kind of approach, I know that's something that we are trying to feed into the National Cancer Plan, but whether it will get there, we just don't know. But you know, there's lots of discussion around what cancer would look like as a long-term condition, fitting alongside other long-term conditions and how they're supported in that way. As I say, it's really early days. We don't know what will end up in the cancer plan, but that's certainly the thought and the feelings that we are having. And again, it's really good to hear that most people do want to continue with cancer care reviews in some shape or form. And yeah, so it's really positive, but we do know that there's probably been a bit of a drop off. I know there was originally a notification around the change of QOF. I'll see if I can dig out that original press release and share it with the group, because somebody's asked about the original kind of communication around that. But there was something from the National Cancer Programme many, over a year or so ago now. So yeah, I'll see if I can find that for you.
Okay, thanks, Amanda. I think it's worth remembering you've probably got a slightly biased audience here, as in we would very much want cancer care reviews to continue. But I don't know if we're reflective of the broader primary care setting.
Yeah, no, of course. But I think it's I think what I'm reassured about is everybody's still trying to push for them.
Yeah, absolutely. It's definitely good to hear. Yeah, thank you. Justine.
Hi, I'm just wondering whether people have cancer care coordinators in their practices or in their PCNs, and whether this is a role that's being used, or will it continue? We did have one. I think we've got a vacancy at the moment, but I know that they were involved in screening uptakes, and I think to an extent in cancer care reviews.
Yeah, I think it would be interesting to see with those roles kind of how they may be kind of used now. The QOF indicators have gone for the CCR, and perhaps they'll be repurposed. It'd be interesting to kind of try and map that, I think, in terms of how their roles might change. But people obviously can put things into the chat as well. I'm just conscious of the time. I can see Sandra, you've got your hand up, so I'll go to you next. And then Dina had put something in the chat that was really interesting. So I was going to ask Dina to say a little bit about that if she doesn't mind. But I'm going to go to Sandra first.
Right, I'll try and be brief. Sandra Smith from West Midlands Cancer Alliance. Prior to the knowledge about being retired, we stood up a care review group who was looking at developing cancer care review standards, which we will continue to do. And we want to promote that as kind of good practice, and this is best practice. So we'll be working with our primary care teams to promote the continuation of cancer reviews. The generic feedback that we're getting from some of our primary care teams, and this is only a small snapshot, is that, again, we know that the reviews weren't delivered particularly well historically, and so we've just seen a kind of drop off of that in terms of practices saying that they're going to continue to deliver cancer care reviews. Training, where they one practice said they'd have about 20 people on training. When they put it out again, that fell to 2. So, we're already seeing the impact. But I think it was interesting what you said, Sandra, about, this being a particularly subjective group. Coming from an ICB commissioner kind of role and working within primary care, I suppose we do have to take into consideration the whole position of primary care and the demands on primary care. So my general feeling is, if that is stood down, if it wasn't consistent before, just think as a collective, what is it we can do to support patients at that particular point in their cancer journey. So what else is there? And again, this will probably, as Hassan said, it will be varied. We're just introducing something where there'll be considerable variation across all our alliances. But what would be great is if we could develop something that would deliver a kind of a consistent approach and something that we could all aim towards.
All right, thanks. I'm just conscious of the time. Dina, you'd put something in the chat that sounded really interesting. So would you mind saying a few words about it?
I will, bear with me. Sorry, I'm having some IT problems. 2 seconds.
If you can, don't worry otherwise.
Yeah, it's fine. So sorry, so I'm here now. So we've done some work with primary care initially around upskilling care coordinators, generic care coordinators and social prescribers in delivering the cancer care review.
I think we might have lost you, Dina. Oh, that's a shame. I think we might have lost Dina. Sandra, did you want to say something else?
Just quickly, when she quickly mentioned that she was doing that training, that's one of the things that we're thinking of doing, because we know potentially in the cancer plan there will be a focus on early intervention and prevention. So we're thinking of working with our systems to kind of promote the value of cancer care reviews within that training. So looking at every single opportunity where you can feed that awareness into other programs of work across the cancer platform.
Thank you. Dina, did you want to have another go?
Apologies. So sorry about that. So since the QOF changes, we're working on something called a community model of support across the different areas in West Yorkshire, and what we've done is identified some community-based assets, so anchor organisations that are already delivering support. So for example, in Calderdale we had a particular organisation, a service called Staying Well, which actually what their focus was loneliness and isolation. So essentially when we unpicked what they actually did, they were really social prescribers, but not with that title. So what we've done is we've actually upskilled them, because they're already having conversations with people, regardless of what long-term condition they've got or not. And so we've upskilled them in delivering those conversations. So they do holistic needs assessments using the Macmillan platform. We've got a data sharing agreement with secondary care. They already work very closely with primary care anyway, with the normal service that they've got. So we've got the data sharing agreement from secondary care so that we can see the holistic needs assessments that happen in secondary care and what the personalised care and support plans are. And then we've got that continuation into the community service, so they can see the conversations that have happened previously and continue that support kind of beyond the treatment phase. So that's kind of what we've done in one area, and we're trying to roll that kind of concept out across the whole of West Yorkshire. So we've got the project managers working on that concept. So those conversations may not happen in primary care as cancer care reviews, but primary care know they can refer that out to this service to have, so the conversation still happens. It's just not happening in a primary care setting. It's happening actually in a community location. And actually, some of the workers that we've worked with are trilingual. They're from deprived areas, so they've already got that trust, and that language barriers are then reduced, things like that. So I could talk about this for hours. So there's lots around this work, but just to kind of give you an idea around where the conversations could shift rather than being in the healthcare setting. So not necessarily stopping, but just moving where the conversation happens.
Yeah, thank you. That's really helpful to kind of understand that a little bit more. And perhaps at a later meeting, you could come back and tell us a bit more about it, and you know, some of the data around it as well. Would be good to see how it's how it's kind of rolling out. And I'm just conscious at the time that we've got 1 minute left. So I mean, the last question was, what can we do collectively? I think sharing resources is very helpful, and sharing ideas around ways to mitigate this is helpful. So I think we definitely need to revisit this at a later meeting. Equally, if people have documents they're producing or cases they're making, business cases, etc. If they're happy to share nationally, I think that would be really helpful as well, to maybe get an understanding about what the opportunities might be, and then collectively I think there is opportunity to think about doing this in sort of new creative ways. And it may not be called a cancer care review, but it's about delivering what's right for the patient and delivering personalised care for the patients at a point when they need it, and that's accessible, and reduces some of those health inequalities. That's certainly the way I'm starting to think about it. But really, really interesting discussion, and really interesting to hear what people are doing. So I'm going to bring the meeting to a close. We will share the recording, and I know there's lots of stuff in the chat which I probably haven't been able to look at. So if there's things which are particularly interesting, I might reach out to you and invite people to come and talk at a future meeting, if that's okay. So thanks everyone, really good to see you, and really interesting conversation. I hope collectively we can take this work forward, to make sure that patients get what they require out in primary care and community settings. Thanks everyone, and thanks again to Justine for speaking.